Welcome to Module 7 of the Foundation Certificate in Trauma-Informed Practice, an online certificate offered by the University of Vermont's Child Welfare Training Partnership. Welcome to this module, Assessment, Treatment Formulation, and Treatment Planning, which was developed by Catherine E. Burns in partnership with the University of Vermont Department of Social Work. Learning objectives for this module include learning about assessment and the types of assessment that are available, understanding the importance of ongoing assessment and how to use assessment to inform case formulation and treatment planning, identifying the role of assessment in evaluating treatment effectiveness, and understanding assessment in clinical practice issues, including supervision and cultural and ethical considerations. As we begin this module, please write down 3 words that come to mind when you hear the term assessment. Some people react negatively to the term assessment, thinking that assessment entails more time and more paperwork. Many people think that assessment is only done at the beginning of treatment. However, you will learn in this module about the importance of dynamic, ongoing assessment, which can improve your effectiveness, increase job satisfaction, and improve your client's experience in treatment. Our hope is to reframe your view of assessment as something you have to do to something that has numerous benefits for providers and clients. We will provide an overview of basic assessment, treatment formulation, and planning skills, and tools to integrate assessment into ongoing treatment. This module from Page and Strisky, 2006, offers a mnemonic that illustrates how assessment fits in the context of treatment. We will use this module throughout the training to illustrate how assessment, in conjunction with your own clinical background and training, is used in varied forms throughout treatment. As you look at the figure, and as we review the components of clinical practice more completely over the next few slides, think about where you tend to spend most time in your practice and which steps you tend to move through more quickly. Commonly, people will spend most of their time in treatment implementation, with less time on assessment and evaluation of progress with treatment. An assumption throughout this entire training is that without a positive relationship with the client, even the best assessment process will not be productive. There is a broad literature that supports the need for a positive therapeutic relationship to achieve optimal treatment outcomes. In fact, Garsky, Martin, and Davis in 2000 conducted an exhaustive meta-analysis for and found that the therapeutic alliance contributed more to the overall outcome for the client than any other variable, including the type of treatment modality used. While this is not a course in how to create this type of relationship, please know that without a positive alliance, the treatment you provide may not be optimally effective. It is also clear that having a treatment that is well matched to the client needs contributes directly to the alliance, as it indicates to the client that his or her needs are understood and are being addressed. Models, such as the one developed by Scott Miller, which is currently being implemented throughout the state, are based upon ratings of the client by the therapist, as well as ongoing ratings of the therapist by the client, including the quality of the relational bond, the degree of agreement between consumer and clinician regarding goals, and consumer and clinician agreement regarding the methods and approach employed in care. The idea behind this model is that with ongoing feedback regarding the effectiveness of the treatment and the quality of the therapeutic relationship, the retention in and subsequent effectiveness of treatment will be improved. We will now return to the science-informed model of clinical psychology practice. Client data represents the reasons for which the client presents for services. It is limited to what the client chooses to tell you and what you are also able to elicit from the client. The red arrows represent the information about the client, some of which remains unknown to the clinician. We never know the whole story, which underscores why ongoing assessment is so critical. This oval is your clinical lens, based on your knowledge of the literature and your clinical training and experience, through which you filter all of the information you are learning about the client. This relationship is dynamic in that the clinicians and the client's responses influence one another. The information collected by the clinician is then used to inform the next several phases that involve assessment and case formulation, treatment planning and measurement, treatment implementation and monitoring, and evaluation and accountability. The arrows indicate that these processes inform one another and are dynamic. In other words, assessment and treatment is very much an ongoing process. with information gleaned throughout the treatment process going back to inform hypotheses developed during the case formulation process. Finally, the results of treatment are fed back to inform the clinician's own lens or clinical practice moving. These results can also be used to inform our broader knowledge base about clinical practice and the effectiveness of our programs for treating and supporting our target populations. For a variety of very good reasons, we are being increasingly asked to back claims about the effectiveness of services. Finding ways to share this information is not only important, but it is absolutely necessary if we intend to remain active participants in the behavioral healthcare paradigm. These suggestions as to what assessment is not might seem absurd, but if you poll a room full of clinicians, you will find that on their worst days, clinicians will admit to these reasons for assessments. While some of the assessments we do might be mandated or might be required for insurance purposes, the true reason we do them is to get a better grasp on what our clients need and how to best support them. It is important to remember that assessment is an ongoing process of hypotheses building and testing, which we do in collaboration with the client. We are all social scientists. This slide introduces the 4 pillars of assessment. We will be reviewing all of them briefly in a moment. Which pillar represents how you gather most of your clinical information? Ideally, you want to gather information from all 4 quadrants. Assessment is never one element. It is a collection of information from a variety of sources that allows you to generate and possibly test hypotheses about what is going on for the client. Norm-referenced assessments are what most people commonly think of when they consider assessment. The main benefit of these kinds of assessments is that they allow you to compare one person to the next based upon a normative sample. They may cover a wide range of domains and symptoms and are administered in a standardized way. Norm-referenced tests are based upon the assumption that all scores in a population are distributed normally, with 68% of the population falling within one standard deviation of the mean, illustrated in yellow. These tests compare the performance of one individual against the scores of a population using this distribution. Where do the people we see in community mental health, particularly those in more challenged populations served by the community mental health, fall? What do we miss by looking at where people fall in comparison to others? We may lose the variability that might be of most interest to us. When you compare averages, you lose the view of uniquenesses that could be potential strengths that foster resilience and recovery. Of course, it doesn't mean normed references tests are ineffective. They just don't tell the whole story. Norm-referenced assessments are used to evaluate a wide range of domains and symptoms. Examples include IQ tests such as the WISC-V, assessments of symptomology such as the Achenbach Child Behavior Checklist, and construct-specific assessments such as the Beck Depression Scale and trauma assessments measures. Construct-specific assessments also include trauma assessment, which is a key element of trauma-informed care. Trauma is prevalent in the general population, and rates of trauma exposure are especially high among high-risk populations, including children involved in the child welfare system. We cannot effectively treat these populations without fully understanding their trauma experiences and needs. Many children in the child welfare system can benefit from trauma-focused treatment, and a thorough trauma assessment can help ensure that they receive appropriate services to meet their needs. Most children will not volunteer information about trauma unless they are asked directly, but many providers are concerned that asking children about potentially traumatic events will re-traumatize them. Studies such as those by Finklor and his colleagues in 2014 show that children do not typically become overly distressed when asked about trauma. In fact, some children report feeling relieved that someone is finally asking them about their experiences and learning that their reactions are normal. Other trauma assessments focus is on trauma-related symptoms to guide treatment selection, inform treatment planning, help children and their families understand their reactions, and evaluate progress in treatment. The Child and Adolescent Needs and Strengths Comprehensive Multisystem Assessment is used in Vermont for children and youth ages 5 through 22 who are involved in the child welfare system. In Vermont, The CANS is administered by mental health providers. It provides comprehensive assessment of the type and severity of clinical and psychosocial factors that may impact treatment decisions and outcomes, including trauma exposure and levels of traumatic stress symptoms. The CANS also assesses for other mental health issues and child and family strengths. An example of a trauma assessment that is widely used in Vermont is Edna Foe's Child PTSD Symptom Scale. The CPSS assesses PTSD symptoms in children 8 to 18. Children are asked to self-report on the frequency of trauma-related symptoms based on their most traumatic event. This yields a total symptom severity scale ranging from 0 to 80, which allows you to gauge the severity of the child's current trauma reactions. Scores can also be calculated for each of the 4 PTSD symptom clusters. Intrusion includes flashbacks, nightmares, and intrusive thoughts. Avoidance symptoms include trying not to think about the trauma or having feelings about the trauma. Negative alterations in cognition and mood include having bad thoughts about yourself, other people, or the world. Hyperarousal symptoms include sleep disturbance, irritability, and trouble concentrating. A total symptom score of 31 or above is suggestive of post-traumatic stress disorder and indicates that the child is likely to benefit from trauma-focused therapy. It is important to provide feedback to the child and family regarding assessment results and use these results to link children to appropriate providers. Normative reference tools have many benefits, including objectivity, efficiency, and the ability to gather detailed information, often from multiple informants. It is important to ensure that you are properly trained on how to use and interpret these tools before using them with clients. The clinical interview can provide rich information and allows clients to describe problems and concerns using their own words. One limitation of this pillar is the phenomenon of demand characteristics, when a client acts a certain way to please the clinician or to present in a socially desirable way. For example, parents may overemphasize what is going well at home and minimize or deny problems out of the desire to present themselves as good parents. Information covered during the clinical interview typically includes basic client demographics and history, as well as presenting problems and concerns and what the client has tried thus far to address the problems. Observation is the third pillar of assessment. Benefits of observation include getting to see directly how the client behaves and responds in sessions as well as in natural environments, including home or school. Limitations to observation include observer effects and demand characteristics, as people will act differently when they know they are being observed. The fourth pillar of assessment is informal assessment. These include clinician-made tests such as ecomaps, genograms, and functional behavior assessments. They tend to be structured. Informal assessments are not normed, but they can provide important and useful information nonetheless. It is important that we use tools that are valid and reliable, so we know we are measuring what we think we are measuring and whether we are measuring the same thing over time. Have you ever used a tool that was not valid or reliable? What are some risks of using tools that are not validated or not reliable? By using reliable and valid assessments, the professional is finding the best information about the precipitants of a client's presenting issue. By discussing these results with the client in a collaborative way, you will find that you will be able to develop the most relevant case formulation and treatment plan that should lead to the best outcome for the client. This collaborative process reinforces the therapeutic alliance. It is important to remember that intervention begins with our first assessment regardless of what tool we utilize. We will now present a case example to help us apply what we have been learning about assessment. Johnny is a 15-year-old Caucasian male who was referred by his foster family and school team for aggressive and non-compliant behaviors. There's a long history of domestic violence between Johnny's parents and physical abuse on Johnny by his father. He was removed from his parents and placed in foster care 2 years ago. Johnny's cognitive functioning, as per the Wechsler Scale for Children, 4th edition, places him in the moderate to mild range of impairment. Johnny presents as withdrawn and quiet. When you interview him, it takes a lot to get him to talk, but he eventually shares that he likes to draw and listen to music. He becomes visibly upset when you ask him about his biological parents and how he ended up in foster care. Johnny tells you he does not want to talk about that. The child behavior checklists completed by his parents and teacher report show Johnny in clinical range for both externalizing and internalizing problems. On the Child Post-Traumatic Stress Disorder Scale, Johnny scored 65 out of 80, representing a high level of post-traumatic distress. You engage Johnny in creating an eco-map to identify sources of support and stress. He identifies that school and his family and peer relationships are mostly stressful, and that he is upset about Dad's recent incarceration, but that he has an art teacher who encourages him and one close friend at school. Using the 4 pillars, what assessment information for Johnny would you put in each quadrant? It may help to draw the 4 pillars on paper and list examples for each type of assessment: norm-referenced assessments, clinical interview, informal assessments, and observations. We will now review the process of diagnosis and treatment formulation. Diagnosis, or describing the client's concerns, leads to case formulation, which is clinically understanding the client's concerns. This leads to treatment planning, or addressing the client's concerns. For accurate diagnosis, the clinician finds the best match between what is learned from the assessment and the DSM criteria. The clinician considers all relevant potential causes and factors based on the clinical interview, assessment tools, case history, and corroborating information, and then eliminates alternative causes by a systematic comparison and contrasting of the clinical findings. It is important to remember that the diagnosis may change as you continue to assess throughout treatment and depending on new information and the client's response to treatment. Like an assessment, a diagnosis is a description of symptoms that serves as a starting place, not a destination. Just like assessment and treatment, diagnosis is an ongoing process that informs ongoing treatment planning but does not dictate prognosis or outcomes. As similar symptoms can be found on different diagnoses, differential diagnosis is essential. Treatment formulation can be defined as a core clinical skill that links assessment information and treatment planning. It can also be understood as a hypothesis about the mechanisms that cause and maintain the problem or symptom by answering the question, why is this person having this type of problem now? Treatment formulation allows you to answer the question, who are you treating, and to integrate assessment information into a coherent understanding of the client and his or her environmental context. Treatment formulation allows us to understand the complexities of the varied components our clients present to us, the causes of the referring problem, and the next steps for addressing the problem. Treatment formulation also leads us to understand what is needed and how this might be provided. Once you understand how and why a person or system functions the way it does, you can begin to develop a map that guides the work using evidence-based or at least evidence-informed approaches. This process ensures that clients get the right treatment to address the true source or sources of their problems. For example, Johnny was referred for oppositional and aggressive behavior, and his parent and teacher report forms alone might lead to a misdiagnosis and inappropriate treatment plan. When you incorporate the results of the CPSS and your clinical interview and observations of Johnny in session, you were able to see that Johnny's trauma symptoms may be driving many of his behavior problems. Your treatment formulation based on your comprehensive assessment would identify trauma as a key treatment issue rather than solely focusing on the behavior problems. The 5 Ps represent a guide to case formulation. State the problem, state the precipitant, describe critical predisposing factors, include statement about perpetuating or maintaining factors, and highlight protective and positive qualities. We will now apply the 5 Ps to the case of Johnny. Please refer to the handout in Appendix D, Assessment and Treatment Formulation Worksheet. Identify the relevant assessment information, strengths, and areas of need from the case example. You may want to refer back to slide 34 for reference. Try to answer the 5 Ps for Johnny. What are his presenting problems, including possible diagnoses? What are the predisposing factors in his history that might be contributing to his current problems? What are possible precipitants or triggers that led him to treatment now? What factors might be perpetuating or maintaining the problems? If the problem is not addressed, are there other issues that might get worse? And what are protective and positive qualities, including social or community resources? Some key questions to consider for treatment planning include: what is the best practice for this problem? What does your training and experience suggest? Which types of interventions will address the predisposing, precipitating, and perpetuating factors? To conduct client-centered treatment planning, consider diversity factors, strengths-based approaches, and the client's views of what services are needed to help overcome the problem. When engaging in treatment planning, we sometimes assume that we know what is best for the client and may fail to share assessment results with the client. We do a disservice to clients when we do not engage them in decision-making or ensure that their preferences and goals are included. This can foster dependency when we ultimately want to empower clients to make their own decisions to enhance their own resilience. Goals tend to be broad, reflecting the client's desire for change and reason for seeking help. A strength-based approach to objectives incorporates objectives that state desired changes in behavior, describe positive changes that build on past accomplishments and existing resources, and reflect an increase in functioning and ability along with attainment of new skills. We need to be sure not to include objectives that are unattainable given the current level of ability of the client or family, not related to the client or family's goals, cluttered with unnecessary information, too general, not clearly specifying the expected outcome, or focused on attendance and/or participation only. We can use Johnny as an example. You may recall that Johnny, age 15, has been defiant with his foster parents. When his foster mother speaks to him, he answers rudely, talking back. This happens every evening. One of Johnny and his family's expressed goals is to get along better. An appropriate objective might include: foster mother and Johnny will spend 5 minutes each day calmly talking about the day's events. This will be measured by self-report, behavioral data, and family observations. SMART goals and objectives are specific and simple, measurable, achievable, realistic and reasonable, and time-limited with a target date. Practice generating some strength-based SMART objectives with Johnny for his self-stated goal to stop having nightmares. As you identify concrete objectives for this goal, be sure to include how you will measure his progress. To develop collaborative goals with clients, we must engage them in the process of helping to define what will work for them and provide guidance with questions such as: if you no longer had this problem, what would you do? And before you started to have this problem, what did you want out of life? We all probably agree that collaboration is important, but we may get stuck on how to achieve true collaboration. Take a moment to respond to the following questions. What is meant by collaboration? What does this look like? What doesn't it look like? How would you collaborate effectively with Johnny and his foster family? Is there ever a time that goals are not collaborative? So now that we have used the 4 pillars of assessment to develop a treatment formulation and have created a collaborative treatment plan with the client, how do we know what we are doing is working? Let's revisit the science-informed model of clinical psychology practice to focus on evaluation and accountability. Are you seeing improvements? It is also very important to ask whether or not the client thinks that treatment is working. This is a dynamic feedback loop that can lead to alterations in the assessment and treatment plan. How can we use the 4 pillars to guide ongoing assessment? Is there a place for ongoing formal assessment? Can you think of some examples? Perhaps we can consider the use of the child PTSD symptom scale that we discussed earlier. If you were to re-administer this measure to Johnny at mid-treatment, what might you expect to see? How would this inform your treatment plan and course of intervention? Could the CPSS also be useful towards the end of treatment? We can use all 4 assessment pillars to help us evaluate when treatment goals have been met. Termination planning starts during the assessment process by asking, how will things look when we are done? Look for indicators that are behavioral that will serve as evidence that goals have been met and note them. It is important to discuss termination throughout treatment to promote a feeling of competence rather than that of loss or abandonment. This is especially salient for our clients like Johnny who have experienced multiple traumas and losses. Consider completing formal or informal assessments to understand the severity of the condition that brought the person to your care. compare these results over time. What is good enough? While we want clients or those who come into our care to experience maximum improvement, we also must be realistic with ourselves and with the clients. Clients in our care often present with multiple risk factors, such as generational poverty, marginalization, addiction, mental illness. In these cases, treatment is not likely to address all of these stressors. Instead, goals that are good enough, such as the ability to continue to participate in a school education or manage chronic depression, may be the target of treatment rather than trying to address and solve all of the presenting risk factors. Without continued learning and supervision from other skilled professionals, we run the risk of having our lens become clouded and myopic. Supervision and training serve to build our skills and ability to treat the different people who come into our care. If you consider the massive expansion of interventions based upon our knowledge of brain development, a clinician who is not keeping current with this literature and subsequent practices runs the risk of, at the least, being ineffective, but at the worst, being harmful to clients. In the medical model, physicians in specialty practices gather once per week for rounds to discuss complex cases so as to garner different views to promote the best treatment possible. Supervision, particularly group supervision, can provide this same function. Some models of treatment, including dialect behavior therapy, place therapist consultation as central to the effectiveness of the treatment in order to ensure the clinician is truly adhering to the treatment model. The primary function of supervision is to monitor client care to ensure it is high quality and effective. Supervisors are well seated to review assessment materials obtained at the beginning of treatment, as well as those throughout the course of treatment to assure treatment efficacy. Using the Page and Strisky model, 2006, there are 4 intervention points and goals for supervision. 1. Professional identity. Here, supervisors can directly impact the clinician's professional identity as a learner and as a clinician who can further the field. 2. Skill development. Supervisors can support the expansion of knowledge and skills of supervisees to include the use of assessment data to inform case conceptualization and treatment planning. 3. Quality assurance. Supervisors are responsible for the provision of high-quality care and can use record review, direct observation, group and individual consultation to monitor client and clinician progress throughout treatment. 4. Gatekeeper function. This is a supervisor's summative assessment to protect client welfare and the integrity of the profession. As with individual assessments, the same assessment tools can be used to measure the effectiveness of a program or agency. Individual data elements can be aggregated to protect the identity of program participants while permitting a view of the percentage of clients who improved due to their participation in the program. Informal assessments, such as surveys, can be conducted for a variety of purposes, with some survey engines, such as SurveyMonkey, providing a very cost-effective way of collecting information from stakeholders. In short, the same process applies and requires views from multiple points to fully inform effectiveness of a program. The most important function of program evaluation is to ensure that we are providing the most effective care. Unfortunately, this is the aspect of evaluation that is often first to be eliminated due to resource constraints. In the current climate, program evaluation has become a necessity, and program administrators are scrambling to find ways to efficiently measure program effectiveness. In fact, the information they need is often available to them as indicated on the prior slide. It is only ethical to practice within the bounds of your training and expertise. As emphasized earlier, it would not be ethical to administer or interpret an assessment measure or process without appropriate training and supervision. It is recommended that you review your particular professional ethical guidelines for assessment for further guidance. It is also important to consider whether a particular assessment tool or method is appropriate for your particular client. If the client does not seem to fully understand your questions, the results will not give you accurate information. For culturally competent assessment, you must know your clients and only use assessment approaches and tools that are appropriate. We must ensure appropriate language and understanding. If you are unsure about the cultural fit of a particular tool or approach, get consultation and supervision from someone who is knowledgeable. Finally, we want to mention the importance of good record keeping in relation to assessment and treatment planning. Good record keeping serves many purposes, including facilitating communication between providers and clients, documenting that you have completed a comprehensive assessment and treatment plan, and to assist with the continuity of care. Good records are relevant, accurate, contemporaneous, continuous, consistent, legible, and comprehensive. In summary, in this module we have learned what assessment is and is not, the 4 pillars of assessment, how assessment informs treatment formulation and treatment planning, the role of assessment and evaluation and accountability, and issues related to assessment and clinical practice. We hope that you will use the information from this module to enhance your practice of comprehensive and ongoing assessment in your practice with clients. Thank you for participating in this training.